Hi everybody. Today we're going to go over the endocrine function and disorders. As you're going through this presentation, what I do suggest that you have at least printed or nearby for you to follow along, just so it kind of helps sink in a little bit better, is I'll have two documents posted. One is a endocrine study guide chart, which is really helpful when you want to break down and look at the hormones, the glands that produces hormones, what happens, and if that hormone is underproduced, what it leads to, and if there's an overproduction, what it does lead to. So this is kind of a good study guide. The other one is basically the endocrine system at a glance that I put together, and it shows kind of the relationship with the hypothalamus kind of being at top here. And let me give you an example. So let's say here in the anterior pituitary, creates the thyroid stimulating hormone TSH, which activates the thyroid to produce T4 and T3, which are basically your thyroid hormones, and that has an impact on metabolism. And so when their amounts are low, the conditions can be hypothyroidism, or if it is high, you're looking at hyperthyroidism. So that would be my suggestion. All right, let's get going into the actual presentation. So this is just a quick overview of the endocrine system. I hope too, before you actually go through this and listen about the disorders, that you have reviewed your anatomy and physiology of the endocrine system. I do have another presentation posted that's about 23 minutes long. That is a good refresher. So I would advise to watch that before you watch this one. So here's a big problem. We're going to talk about the pituitary, but when you are doing a patient assessment, if you look at all these different signs and symptoms, they can be related to so many different things. And unfortunately, it will be a combination of symptoms, length of the symptoms, but also lab work to determine any hormonal changes. And that's the other thing you have to kind of get stuck in your head, that as we're talking about the endocrine system, we are talking about hormones. So pretty much everything we're talking about is hormones. First, we're going to start with the pituitary disorders. The problem with pituitary disorders, you're either going to have an oversecretion or undersecretion. And when we talk about the pituitary, you're going to have both your anterior and your posterior. So it's going to be a matter of, is there oversecretion of one or the other, or undersecretion of one or the other. And you also have to think too in relationship to where the pituitary is when we talk about certain disorders. Throughout this presentation, things that you see shaded in blue are going to be things that you will need to focus in on for studying purposes, or slides that you see stars. There are certain conditions that you will need to know in depth, and those are going to be highlighted in blue or have stars. The others, you just need to know cursory information in terms of where is the dysfunction coming from. So with pituitary tumors, some of the pathophysiology and some of the signs and symptoms that we're going to see in patients is going to be headache and visual changes like pressure. And again, if you think about where the pituitary is, if there is a tumor in relationship to the eyes, it kind of makes sense. It can be life-threatening depending on the target organ in terms of where there is influx in hormones. Typically, there are three types. It's always an overgrowth of some sort of cell. The most common is your prolactinomas, which is secretion in prolactin. Risk factors, There is hereditary is a big one, and also having the MEN1 gene. With diagnosing, it's going to be a matter of visual acuity, CT and MRI to actually look at the size and function of the thyroid, and also looking at serum levels. Obviously, if you have a tumor, the only way to deal with it is through surgical treatment, and the type of surgery is called a hypophyseectomy. And at least for testing purposes, you don't need to know these medications in terms of pre and post-op. The type of surgery, at least the route that is taken, is the transsphenoidal route, which is actually up through the nares. So again, if you kind of look where the pituitary is, that's the most direct route. But keeping that in mind, what you need to do is discuss ways to reduce the increase of intracranial pressure preoperatively with your patient. So you want to make sure your patient doesn't bend over, doesn't strain while going to the bathroom, keep the head of the bed 15 to 30 degrees, and the body midline to avoid any type of neck vein compression. Post-operatively, you want to reduce CSF leaks. So you want to make sure that your patient doesn't vigorously cough, blow their nose, suck through a straw, or sneeze. Way to monitor for CSF leaks is if there is clear drainage from the nose or the ear. And typically, if it's through the nose, it will typically just come out one of the nares. Also, there's something called the halo ring test. And what you're looking for in terms of a halo ring test is, let's say your patient gets up to go to the bathroom, and on their pillow, you see an area. Let's see what I can do here. Alright, this is not the best representation, but it should help some. Alright, so you have a patient that gets up to go to the bathroom, you come in to check on them, and on pillow, you see that there's some drainage, and the inner portion of it is red because there's a little bit of blood, but around the outside of it, and it's not this yellow, but you will see a discoloration, which is indicative of a halo ring. And what substance this is and why it's slightly discolored is because in cerebral spinal fluid there is glucose, and so this is actually glucose, and it's so slightly stained. So this would be your halo ring test. Other things you need to do for your patients post-operatively is good oral care and monitoring their daily weights. And the reason why you want to do good oral care is this person may be doing a lot of mouth breathing since they just had surgery up through their nose. So the first symptoms, a syndrome we're going to talk about as relates to the pituitary, and you do see that it is starred here, so you need to know this one in depth, is Cushings Syndrome. This picture is a good representation. This is when there is an oversecretion of ACTH, which is the adrenocorticotropic hormone, from the anterior pituitary, and that stimulates the adrenal cortex to overproduce cortisol. So when somebody has an overproduction of cortisol for a long period of time, it will affect a person's height. They might be shorter statured. They may be overweight. They may have muscular skeletal changes and intolerance to glucose. In terms of nursing management, we have to look at safety, preventing infections, promoting skin integrity, and body image. So what I mean by that is, again, cortisol is a steroid, so long-term effects, it thins out the skin. You might see increased purple stria, bruising and petechia. Moon face is something you'll hear a lot. You'll see a lot of times in testing purposes. Also, if somebody has a high level of cortisol, which is a steroid, it makes somebody susceptible to infection because it makes you more immunocompromised. And also with glucose intolerance, usually cortisol makes a person more insulin resistant, and so they will have elevated glucose levels. There's obviously some other symptoms here, but those are the ones that typically stand out to most students. So here's a question to check your understanding. Is the following statement true or false? And take a few minutes to review this. I hope you said true. A lot of times it is often caused by an overuse of corticosteroid medications. Acromegaly, there is not a star anywhere here. The only thing you need to know really about this condition is that it is an oversecretion of growth hormone from the anterior pituitary. Testing is usually done by the oral glucose tolerance test. And why is that done? It's because as the glucose levels increase, a growth hormone should be suppressed. Diabetes insipidus. Usually diabetes insipidus, the patient will have a history of either a head injury, a pituitary tumor, or a craniotomy, which it can be, in terms of craniotomy, a complication. So this is when there is a undersecretion of ADH, which is antidiuretic hormone, by the posterior pituitary. And if you watch the first video that goes over the anatomy and physiology of the endocrine system, ADH is the only hormone, at least for testing purposes, that you need to know that is stored by the posterior pituitary and released. So when there is a deficiency in ADH, also know that it's called vasopressin deficiency. It is characterized by excessive thirst, which is also known as polydipsia, and large volumes. And here's the key word: dilute urine. And this is a good, if you're a visual person, this is a good slide to kind of look over the signs and symptoms and the nursing care. Types and causes, there are typically three. Neurogenic, which is damage to the posterior pituitary gland itself. Nephrogenic, which has to do with the kidneys. A lot of times that is related to drug damage to the renal tubules that prevents the kidneys from conserving H2O or water. And psychogenic can be from the result of excessive water intake. So I can remember there have been, I almost want to say it was a radio talk show that may have had a contest of how much water somebody could drink, and somebody actually ended up dying from having excessive water intake, having an onset of diabetes insipidus. You really don't need to go into depth, but just understand that there are 3 causes, and I think if you think them through, hopefully they will make sense. Signs and symptoms. So if somebody has dilute urine, you're looking at a large amount, between 30 to 20 liters per day. Obviously, sleep is not going to stop somebody, so there is nocturia. You're going to see a decrease specific gravity of 1.001 to 1.005. Obviously, if you're losing a lot of fluid, you're going to have signs and symptoms of fluid volume deficit. One of those being increased serum osmolarity of greater than 300. Diagnostic tests that you just need to do is the vasopressin challenge test, because obviously if you give somebody vasopressin, it should reverse the effects of the loss of ADH. Or you can also do a fluid deprivation test. It's obviously contraindicated if somebody has high sodium levels, but if you deprive somebody from fluid and they continue to lose a large amount, it also helps to confirm the diagnosis. Treatments obviously is to replace the ADH through vasopressin, which is a synthetic of ADH. It also, you want to ensure adequate fluid replacement and to identify any underlying etiologies if possible. Because of the vasoconstrictive properties of vasopressin, it shouldn't be used with patients with CAD, CVD, or hypertension. So this is arterial disease, cardiovascular disease, or high blood pressure. In terms of watching patients, you want to watch their fluid volume, obviously, since that is kind of the big problem we have going on. Monitor their weights, monitor vital signs. And if this is going to be more of a lifelong thing, patients should wear a medical alert bracelet. The treatment for it that you should know, obviously, is going to be vasopressin. And what kind of throws off students is the use of thiazide diuretics. One, it actually helps to increase the effects of vasopressin, but it almost has an opposite effect. It creates a sense of mild hypovolemia, and the way that the kidneys respond to thiazide diuretics is the uptake of sodium and water. So it actually helps promote the retention of fluids, where the person is having the opposite problem, where they're having a whole hard time because of that lack of that ADH. So that is why in this particular case thiazide diuretics are used, and they actually kind of have the opposite effect that most people think about. So here's a check your understanding question. And here's your answer. So, syndrome of inappropriate antidiuretic hormone. This is going to be your opposite of diabetes insipidus. And just a side note on diabetes insipidus, it has nothing to do with diabetes mellitus. So in talking about syndrome of inappropriate diuretic hormone, some of the symptoms of SIADH is too much fluid. And so we call Mr. Soggy Sid here. High blood pressure, tachycardia, and an elevated specific gravity, dark urine, and a lot of times patients will need fluid restriction. And of course this is going to be the result of an oversecretion of ADH. So the problem now with somebody having too much fluid is they are susceptible to what's called dilutional hyponatremia. So you're basically, your sodium levels will be lower as it circulates in the bloodstream, and you will see a serum osmolarity less than 275. Risk factors are usually non-endocrine in origin. Cancers can have effect that can cause ADH to be synthesized and released. Pulmonary diseases, head injury, brain surgery, tumors, infections, HIV, and certain medications, which you can see, again, ironically, you have a flip side with using thiazide diuretics. And tricyclic antidepressants also have an anticholinergic effect a lot of times. Obviously, signs and symptoms would be of fluid volume overload, hyponatremia, have an increase of your urine sodium, which is different of having the decrease in your serum sodium levels. Obviously, weight gain and change of level of consciousness. Because of the imbalance with the sodium, one thing you need to watch is that you need to put the person on seizure precautions. The way to correct severe hyponatremia is actually through a hypertonic solution of 3% sodium chloride. One thing you want to monitor with a patient like this, obviously since we're dealing with a fluid imbalance, is to watch their fluid intake and output, their daily weights, urine and blood chemistry. But if you are giving a patient a hypertonic solution for this to correct the sodium levels, you also want to monitor that administration of the 3% sodium chloride to prevent central protein myelin lysis, which is basically a neurological disease that damages the myelin sheaths of the nerve cells in the brainstem. Here's a check your understanding question. I think I just kind of beat it to death, and hopefully you got it correct. So now would be a good time to pause, take a potty break, walk around, let what the first 24 minutes of this presentation that we've discussed. And so we can move on to the next section. So we're going to talk about thyroid disorders. Again, patient assessment. If you look at some of the issues related to thyroid, again, a lot of other organs may need to be ruled out, other systems, but again, it's going to be a culmination of symptoms and lab work to pinpoint if there are any hormonal changes. The one that a lot of students are familiar with when we talk about thyroid is going to be low thyroid levels, which is hypothyroidism. And this is typically when there is a decrease in T3 and T4 production with high TSH levels from the anterior pituitary. Manifestations are divided into early and late symptoms, and are represented basically of a slowing of the metabolic process. So the last presentation that went over the anatomy and physiology of the endocrine system, what I talked about is that when you think of thyroid, just think of metabolism. So if you look at these here would be your early symptoms, where this little box here talks about your late clinical manifestations. And the one that a lot of people are typically familiar with is weight gain, but there are some others, apathy, dry skin, constipation. Just think of things that are like slowing down. People have anorexia, which is completely different from weight gain. It's kind of a lack of appetite. Extreme fatigue, dull, blank expression, can have some edema, and intolerance to cold. In terms of hypothyroidism, you can have it again just simply with a decreased production of T3 and T4 with high TSH levels, but also it can be result where the immune system actually attacks the thyroid, and if that's the case, it is actually classified as Hashimoto's disease. Some of the risk factors, unfortunately, women, you're going to be more susceptible. Typically the range is between 30 and 60 years, and screening is typically recommended for women over 50 if one or more symptoms are present. Sometimes other ways that hypothyroidism can occur, unfortunately, if somebody has hyperthyroidism and they do radiation treatment, they're going to ultimately be have hypothyroidism, just because you have to you end up basically damaging the thyroid and its ability to produce thyroid hormones, and so those individuals regardless will still need to be on some sort of thyroid hormone replacement, and then of course thyroidectomy. So the life-threatening and typically there's a high mortality rate associated with it is what is known as a myxedema coma. The way I try to remember this is if we're talking in terms of metabolism, and with hypothyroidism it's already slowing down, that I think you slow down to a point where you are basically put in a coma. This is usually seen in patients over 50 years. If they slip into a myxedema coma, they're usually hypothermic, have lost consciousness, everything is slowed down, they have a depressed respiratory drive, which can lead to the retention of CO2 and lead to necrosis, and it kind of precipitates the coma. It can occur in undiagnosed hypothyroidism, but it also can follow an infection, some sort of a systemic disease, or sedating medicine. And like I said before, unfortunately, there is a high mortality rate with it. Treatments for hypothyroidism is hormone replacement. So objectives here to replace the missing hormone. So the synthetic is levothyroxine, which is your generic, which is T4, or Synthroid, which is the brand name. If an elderly person is given this medication, Unfortunately, long-standing hypothyroidism can lead to some cardiovascular issues. So if that is the case, you usually need to start low and go slow with those patients. Monitoring management, again, it all has to do with how severe their hypothyroidism is. You want to monitor blood glucose, just because when you're thinking of metabolism, the liver has gotten a little sluggish, and the liver is involved in the synthesizing and producing glucose for the body. In terms of medication education, you need to know all these components in terms of levothyroxine, so please make sure you're familiar with all of these. So here's a check your understanding question. So the flip side, we're going to talk about hyperthyroidism and in relationship to metabolism, where with hypo, everything was kind of slowing down. Think of the opposite effect. Everything is revved up and kind of in overdrive. This is basically when there is an overproduction of T3, T4, or both by the thyroid. So this person will have an intolerance to heat, fine hair, bulging eyes is always one of the characteristics you see in pictures. That's usually going to be a little bit more of a late symptom. Another is the goiter, where it's kind of an overgrowth, which is this enlarged thyroid. Face flushing, tachycardia, increased systolic blood pressure, weight loss, muscle wasting, increase in diarrhea, finger clubbing. There's always going to be menstrual changes that happens with both hypo and hyper, and localized edema. But again, just kind of think of the opposites between the two, of hypo and hyper. Risk factors and complications, just like with hypothyroidism having an autoimmune origin with the Hashimoto's, the opposite with hyperthyroidism is called Graves' disease. And the way that I remember this is that your metabolism is so revved up that you're going to drive yourself right into a grave. And again, unfortunately, is more common in women. It can occur after a stressor or infection. Another stressor where some women actually acquire Graves' disease is pregnancy can be the cause. The medical crisis with hyperthyroidism, where the myxedema coma was with hypothyroidism, it's going to be a thyroid storm or a thyrotoxic crisis with hyper. And this is life-threatening. Multi-symptoms are typically involved. And again, just kind of think of a car that is overheating. You're going to have high fever, tachycardia, exaggerated hyperthyroid symptoms, so weight loss, abdominal pain and diarrhea, cardiovascular edema, and chest pains and palpitations. And a lot of times these folks will be delirious, have an altered mental state. Treatments for basic hyperthyroidism typically is going to be radioactive iodine, because again, if you reviewed the anatomy and physiology of the endocrine system, we talked that iodine is needed for the production of T4 and T3. And so if you give somebody radioactive iodine, it will actually damage that part of the thyroid. The problem again is once you actually damage the thyroid, patients a lot of times become hypo have hypothyroidism and still have to be on lifelong hormone replacement. Anti-thyroid drug therapy will actually prevent the synthesis of the thyroid hormone, but the most serious toxic side effect of it is agranulocytosis, which is marked by a decrease in number of granulocytes. So this is very important to know. And I'll talk on the next slide what those anti-thyroid drugs are. Another type of treatment would just be removing the thyroid altogether. But again, once you do that, a person will have hypothyroidism and still need to have hormone replacement. When a patient has hypothyroidism or is starting to have a thyroid storm, you typically want to provide a calm and quiet environment for them, monitor their body temp, glucose monitoring, eye care, especially if somebody's in late stages, if they're having the bulging eyes, and also just signs and symptoms of infections while on antithyroid hormone in terms of the granulocytosis. So thyroid storm signs and symptoms, again, is the high fever, tachycardia, exaggerated symptoms. Treatment basically is to try to decrease that over-exaggeration of their metabolic rate. So you want to get their body temperature down, get their heart rate down, and basically prevent vascular collapse. So you're going to try to cool them, watch their glucose levels, because again, everything's in overdrive and you almost don't want to clunk out their liver. Acetaminophen is used to control the fever. Never use aspirin with a patient who's in thyroid storm because it will actually displace the binding of proteins and make the hypermetabolic state even worse. Give them humidified O2 because again, when we talked about thyroid function, it also regulates how O2 is used by the cells. So we want to basically try to improve tissue oxygenation and meet the metabolic demands of the body. Give a patient IV fluids and dextrose to basically help replace the glycogen that the liver is using because it's kind of overproducing glucose and releasing it out into the body. The two antithyroid hormone drugs that you need to know, antithyroid drugs that you need to know that will block the T4 and T3 is P2U or methimazole. And you'll need to know that for testing purposes, and you also need to know that, I'm sure, for NCLEX as well. Beta blockers can be used to control cardiac symptoms. Hydrocortisone can be used if a person is going into shock or is having some adrenal insufficiencies. And large doses of iodine can also be administered because it will actually diminish the output of T4. So if the body gets too much, it actually kind of slows down that production. Causes of goiters can be lack of dietary iodine, high levels of TSH, Graves' disease and Hashimoto's disease. But we don't see this as common in the United States as we do some third world countries. But unfortunately, it still exists. Here's a side-by-side comparison of the symptoms of hypothyroidism and hyperthyroidism. And so you do see there is some similarities, but in relationship there's a lot of opposites as well. Another check your understanding. Parathyroid disorders. Alright, parathyroid glands. They are involved in the regulation of serum calcium levels. So this is a great picture that kind of shows you the relationship. So let's look here. So if there's an increase in the serum calcium levels, let's see, probably not the best place to start. I'm trying to see the best place to start here. Okay, so we start off in homeostasis and everything is looking good in the blood, and then we flow this way. We start to have a fall in our serum calcium levels, and so that will stimulate the parathyroid glands to produce PTH. PTH will then stimulate both the release of calcium from the bones back into the bloodstream to elevate it. It will also stimulate the kidneys that will reuptake calcium in the tubules of the kidneys, and so it won't be released in the urine, so that goes into the bloodstream. But there's also an activation of vitamin D that will actually help increase absorption of calcium in the intestines from food that we eat that goes back into the bloodstream. And once that happens, we're back at homeostasis again. So again, this is another kind of feedback loop, but the one thing you need to realize here that you don't see the anterior, posterior, pituitary, or the hypothalamus involved. It's all about the fluctuations of the calcium levels within the serum or bloodstream. So in terms of hyperparathyroidism that you need to know, it's just an excess of PTH that leads to increased calcium levels. Usually the source of it is tumor, or it can also be a result of chronic renal failure. And that's about the most that you need to know. In terms of diagnosing it, this is a good little mnemonic in terms of the signs and symptoms of hypercalcemia, which is stones, bones, moans, and groans. And basically what that relates to is stones, which are kidney stones, bones. In extreme cases, there's some like bone pain. Moans is from abdominal pain, and groans is just irritability of a person. The way to treat it is hydration therapy, and one thing to avoid are thiazide diuretics because they actually decrease the secretion of calcium. And instead, what could actually be used, and depending on the patient, is, since you want to avoid the thiazide because it kind of holds on to the calcium, is loop diuretics can actually help get rid of some of the calcium. Things you want to also, in terms of nursing, you want to avoid dehydration and educate your patients about signs and symptoms of renal stones, which is going to be your abdominal pain, and there could be some hematuria, and encourage mobility by the patient, which you want to stop and think, like, why mobility? But anytime somebody uses movement, it actually promotes calcium to go back into the bones. In terms of hypoparathyroidism, you need to know the symptoms, which the best way to remember them is through this acronym of CATS, which is convulsions, arrhythmias, tetany, spasm, and stridor. And unfortunately, because early signs and symptoms are vague, lab work is typically the only way to see if there's some subtle changes in calcium levels. And x-rays can actually look at if there's increased bone density. So this here again is going to be perpetuated by a decrease in the parathyroid hormone, which leads to a decrease in serum calcium levels. Causes could be removal of the parathyroid, which unfortunately happens at times when a patient is having a thyroidectomy, heavy metal exposure, and also magnesium depletion. But the big thing you need to know are the symptoms here, and these are typically late symptoms. Signs and symptoms: you're going to have irritability, the tetany, which is basically a steady muscle spasms, and that usually is going to develop excuse me, at serum levels that are at between like 5 and 6. Treatment is going to be emergent when tetany is present. You want to give that patient IV calcium glutamate, sedatives for seizure activity, and parenteral PTH. In terms of nursing, you want to put this person on seizure precautions. You want to talk to them about diet that are high in calcium, low in phosphate, and also monitor, do cardiac monitoring. And just to kind of go back, you can look at the clinical tests for hypoglycemia that I know Miss Ellison has gone over in class. The Trousseau sign, and also, and I always botch this, but the Chevstek sign, I think that's how it's pronounced. But you want to know both of these clinical signs as well. Adrenal gland disorders. So when we talk about adrenal glands, don't get confused. The cortex and medulla have different functions. The cortex is activated by the adrenocorticotropic stimulating hormone that is released from the anterior pituitary, where your medulla, which is in the middle, is actually activated by the sympathetic nervous system to produce catecholamines, and the three are epinephrine, norepinephrine, and dopamine, which are neurologically related. So when you're doing assessments, you're looking at a person's fluid balance. You're going to look at the patient, see if they exhibit any of these kind of like signs and symptoms. If you're thinking about fatigue of the adrenal glands, ask about weakness, fatigue, appetite, and weight loss. But if the medulla is actually suspected, then you want to talk to a patient about stress level activity in terms of headaches, anxiety, nervousness, tachycardia, and sweating. Only thing you really need to know about phenochromocystoma is that it is a tumor of the adrenal glands. The signs and symptoms are typically the 5 H's: hypertension, headache, hyperdrosis, which is basically excessive sweating, hypermetabolism, and hyperglycemia. Medical management: get rid of the tumor. And that's all you need to know about phenochromocystoma. Phenochromocystoma. That's right. Okay. Say that about 5 times fast. All right. Addison's disease. Only things you need to know about Addison disease is that it is a decrease. The adrenal cortex function is inadequate to meet the patient's need for cortisol hormones. So basically, the release of these hormones are decreased. There was rumor that perhaps President Kennedy might have had Addison's. We're unsure, but the adrenal cortex, in terms of the cortical hormones, we're talking about cortisol, aldosterone, and the androgens, which are our sex hormones. And this picture here kind of goes over some of the signs and symptoms: weight loss, bronze, pigmentation of the skin, change in the distribution of body hair, GI disturbances, hypoglycemia, and postural hypotension. An adrenal crisis, which is the extreme form, you're going to see profound fatigue, dehydration, and you're going to see a decrease in serum sodium and an increase in serum potassium. And basically, your renal system starts to shut down. We won't talk too much about an adrenal crisis, but know that that is the extreme form of Addison's. In terms of Addison's, it's usually autoimmune. Secondary can be a lack of pituitary ACTH. Risk factors: surgical removal or infection. In terms of the skin pigment changes, this can take a while, but the reasoning behind it is because low cortisol levels causes a hypersecretion of the ACTH, which increases the melanin synthesis in the skin. And so as that increases, you're going to see it particularly at skin creases and pressure points in the buccal mucosa. So you see this picture here, you can see in these areas where the pigmentation is darker, or they call it bronzing. Addison disease, with the crisis, you just want to treat for circulatory shock, monitor fluid and electrolytes, hormone replacement, avoid individuals with infections, and the big thing here is with the Addison crisis, is to watch for hypovolemic shock. But again, really the only thing I would want you to know about Addison's for testing purposes is that, it is a decrease in cortical hormones, which are these three areas here, and also just know some of the more highlighted symptoms like pigment changes, but I won't hold you responsible for the treatment of Addisonian crisis. Oh my goodness, I swore we just saw this slide not too long ago. So Cushing's Syndrome, deja vu. It's a pituitary disorder, but it can also just be a adrenal cortex disorder where there's an oversecretion of ACTH from the anterior pituitary that stimulates the cortex to overproduce cortisol, but there could just be simply a problem in adrenal cortex that overproduces cortisol. Some of the elaborations on the signs and symptoms: virtualization is when basically you see masculine traits on a female. So females will have some facial hair. Diagnostics: do a dexamethasone suppression test. Medical management: a lot of times, if it's the adrenal gland itself that's causing the problem, is a removal of the adrenal gland. And unfortunately, sometimes too, it can also be caused by an overuse of too much steroids, so you can also reduce the steroids. And again, having too much steroids, we know that it can make somebody more at risk for infection, so we want safety, prevent infection, promote skin integrity, because long-term use of steroids or being exposed to them can thin out the skin. So somebody who has Cushing's, just think about the skin integrity. So let's say you had to move a patient from a gurney to a bed. You don't want to slide them because you could put them at risk of shearing the skin. You would want to pick them up, have several people pick them up with a sheet and kind of lift and move over gently versus a sliding action. So side-by-side comparison of Addison's versus Cushing's. Take some time to look over to know the difference between them. And I'm going to end on this little cartoon. Ice cream. Sounds good about now. If you have any questions, let me know. And that's a wrap.